Hello, everyone, and welcome to this audio podcast. This audio podcast, as part of an erythropoiesis edition. This audio podcast as part of a hurricane Plexar. This audio podcast as part of a Labonix Vendip, and this audio podcast as part of a Storm Robotics production. This audio podcast will go into sort of highlight a little bit around the sort of the sort of the sort of a basis in around renal failure as a generic from a generic basis. And in on social media as part of this audio podcast series, there will be a sort of link to works or citation similar to that which has been which has been utilized as part of this works as well. So renal failure then. So renal failure is the degree of renal insufficiency or deficiency causing extensive changes in plasma and serum urine biochemical in serum and urine biochemical in around serum and urine biochemical constituent aspects or components. Renal impairment is identified to be acute if insufficiency occurs over hours or days, and chronic renal failure if spreads over if spreads in line to the severity is referred to as insufficiency over months or years. Acute renal failure is also the generic terminology used to define an abrupt decrease in renal function adequate to result in withholding of nitrogenous waste. So nitrogenous waste, by the way, in context of renal failure or renal disease, for example, is where or perhaps the most important aspect in context of in context of renal insufficiency. And this is referred to as BUN, or blood, urea, and nitrogen, where the three components, for example, the aligned to blood or the hematology component, the urine, the urea, and the nitrogen or nitrogenous waste, BUN, and creatinine, where there's maybe three or four sort of parts, which contribute to sort of the renal sort of renal insufficiency, but the renal insufficiency, but also the syndrome, the sort of syndrome around acute renal failure. And also where in literature now acute renal failure, or ARF, is sort of seldom used. The terminology, for example, is now it tends to be referred to as AKI, or acute kidney injury, and the trait of sort of ARF or renal failure is also progressive. Is progressive sort of azotemia, which again sort of terminology which is again sort of seldom used in line to renal insufficiency. However, caused by the buildup of nitrogenous end products of metabolism. This addition is accompanied by a sort of a broad range of other disturbances, depending on the severity and extent of renal insufficiency. These include metabolic derangements such as biochemical acidosis, hyperkalemia or hypotassium, disturbances of body fluid balance and the effects on many other organs or organ systems. ARF or acute renal failure is commonly encountered in the practice of medicine, where literature has informed retrospectively in previous literature in around 4 to 5% of hospital admissions to an all-purpose medical and surgical ward, where uh, um, where where patients or recipients are where patients or recipients tend to be monitored. And this disorder is less common. It tends to be less common in pediatric renal sufferers than in adult patients or recipients, owing to the population differences between pediatrics and adults. However, to inform that the etiology and in around the renal parenchyma, and around parenchyma is generally sort of compromised, and thus the onset of renal disease can in pediatrics also mean that unfortunately the diagnoses the diagnosis spectrum the diagnosis spectrum can be unfortunately more detrimental than that of those who are diagnosed in the general adult population with renal insufficiency or renal failure. So rapid renal decline and failure is a final mode pathway for a number of disease developments, and is associated with noteworthy sort of morbidity and mortality. Given the high frequency of this disease, or sort of a higher frequency in more recent literature, the multiple cases and significant morbidity, a logical clinical approach to ARF or acute renal failure has been required to help illuminate the cause, and then to proceed with the appropriate or applicable sort of treatment, applicable treatments or applicable therapies. Now, the diagnosis of ARF, again acute renal failure, implies the development of renal morphological and functional abnormalities. There are many causes. And more essential topics include, for example, causes of physiological oliguria, if uncorrected. Now, oliguria is terminology that's referred to where recipients who are diagnosed have a complete unfortunately have an incomplete ability to number one, where they may have the micturition or the sensation of wanting to void urine, but unfortunately are sort of unfortunately completely unable to void urine, owing to the pathophysiological nature in around the diagnoses. So oliguria, all causes of pathophysiological oliguria is generally a concern more so in pediatrics versus in adults if uncorrected. Complications of surgery, especially in abdominal, cardiac, cardiac or aortic surgery, and particularly if the recipient has an infection or is jaundiced. A complication of burns, especially if more than 70% of skin is destroyed, and the loss of plasma causes hypovolemia or low volume in around the important electrolytes, and these recipients often become infected. At the same time, acute decompensation of chronic renal impairment, acute on chronic renal failure, acute renal failure, where acute renal failure is also sort of a is also where chronic renal failure subsequently follows, or subsequent, where the division between acute renal failure and chronic renal failure are for example quite close in context of diagnoses. Now, direct nephrotoxins. So historically, gentamicin being sort of an important antibiotic treatment, non-steroidal anti-inflammatory medication, medications such as rifampicin, paracetamol or acetaminophen, contrast media, or at least in some parts, and including radiopaque substances, and carbon tetrachloride and ethyl glycol have been noted and evidenced as important or essential nephro, important nephrotoxins in context of sort of treatments. Acute obstruction of the urinary tract is not a parenchymal disease, or part of parenchymal disease, but it can cause issues. Acute proliferative nephritis is a rare occurrence, though hematuria is where recipients void blood as part of voiding in an attempt to void urine, and is a very common condition in uh, in where acute renal failure, or where acute parts of acute renal failure are applicable, but also in line with renal, looking at renal morphology, aligned to renal morphology, and at the same time, uh, complications of trauma can cause blood loss from fractured bones, with possible parenchyma infection, and sort of muscle damage, with a release of myoglobin. Though in literature, in more recent literature, myoglobin in line with different forms of acute renal failure and or chronic renal failure. Myoglobin has not been sort of one of the sort of main aspects of part of the diagnoses in sort of more recent literature. However, thus to inform, is important is important in context of trauma, and where trauma is linked to sort of fractured bones with possible parenchymal infection and muscle damage in pediatrics or young people with parts of in aligned tube specific diagnoses around renal failure sort of historically. At the same time, some additional or some common causes of acute renal failure. So, for example, where there's decreased effective intravascular volume and total body volume depletion, there can be a sort of a sense of hemorrhage, gastrointestinal loss, general renal insufficiency as part of the decreased effective intravascular volume, and also where in literature there has been where skin loss can or has been attributed to some causes of renal failure. And also at the same time, where there's volume redistribution. So recall there was a mention in around hypovolemia or low volume in around different electrolytes. So where there's varying volume around important electrolytes, the volume redistribution in around these electrolytes can be linked to sort of a common cause of acute renal failure as well. And at the same time, where as part of this where in around sort of a decreased cardiac output, left-sided failure, right-sided failure, and valvular heart disease, and then there are causes in around renal vascular disease, and where it's been mentioned in around sort of gastrointestinal loss, vomiting or diarrhea, vomiting or diarrhea, or nausea and vomiting and diarrhea have been linked to gastrointestinal loss, but also linked to different forms of renal failure. In around renal loss, examples such as use of diuretics and salt-losing nephritis, diuretics and salt-losing nephritis, sort of historically have been examples in line to specifically around renal renal loss, sort of specifically. And where there was a mention in around skin loss as sort of examples through burns, and also through sweating, as well. In around volume distribution as sort of examples in around what's been referred to in literature, at least retrospectively, around third spacing of fluids. So examples, for example, include peritonitis, or where peritonitis has been evidenced, ascites, pancreatitis, and hypoalbuminemia, sepsis, and anaphylaxis. In around sort of the in around examples of where right-sided failure or valvular heart disease, in around left-sided failure and right-sided failure. The examples include include cardiomyopathy, where the heart or the muscle cells of the heart are ineffective, and also pulmonary embolism, where the lungs where the lungs can be affected, and also there are in around some intrinsic causes of ARF or acute renal failure. There are primarily there are three there are three sorry there are yes there are three main sort of main three main parts in around the intrinsic causes. So there's the glomerular side, the tubular interstitial, and then the vascular. In and around some of the examples, so in around glomerular, there's primary and secondary, and where primary and secondary are linked to examples such as post-streptococcal and rapidly progressing glomerulonephritis, and then also systemic lupus erythematosus or SLE, and vasculitis and endocarditis. In around the tubular interstitial, there's ischemic, and there's nephrotoxin. There's also allergic interstitial nephritis, interstitial or non-drug nephritis, metabolic toxin, and also in around sort of those sort of heavy sort of metals which form components linked to or attributable to tubal interstitial forms of intrinsic causes of acute renal failure. So in around some of the examples, acute tubular necrosis or ATN, aminoglycoside use. So for example, again, gentamicin, radio contrast, pigment and carbon and tetrachloride, and methoxyfluorine, and in around some of the examples of, for example, around allergic interstitial nephritis, interstitial and non-drug nephritis, for example, and metabolic toxin and heavy metal intrinsic causes of acute renal failure. There's drug induced, there's immune complex, uric acid and calcium, for example, and in around the sort of heavy metal aspect, there's historically in literature cisplatinum has been documented. In around the vascular aspect of intrinsic causes of ARF or acute renal failure, there's been atheroembolic and small vessel. So examples in around this include scleroderma, and malignant hypertension, and disseminated intravascular coagulation or DIC, and TTP, which is sort of in around a hematological component, referred to as a thrombotic issue in around these sort of small vessels, in around the small vessels, but in around specific forms of acute renal failure, or part of diagnosis where vasculature can be generally compromised. In around the sort of pathophysiology of post-renal ARF or acute renal failure, the main anatomic sites include pre-renal, intrarenal, and post-renal, and so in around some of these in around pre-renal generally is where anything up until up to the point of where the in line of pathophysiology and anatomy, where the kidneys before the urinary tract, but where the urinary tract connects to the parts before the urinary tubules, the main urinary tubules, and where anatomically these parts or the parenchyma or pathophysiology in around those parts are affected. In around the intrarenal, there can be a susceptibility where recipients are susceptible to general forms of ARF, or acute kidney injury, or acute renal failure, glomerulonephritis, and acute tubular causes. And then at the same time, acute interstitial nephritis as well. And then there's the post-renal, so anything that in context of the anatomy, anything after, for example, the bladder, or anything after the bladder, and anything that is aligned to the parts of renal tubules, but also after the bladder. So in literature, there are some examples of some of the sort of sediment aspects around, for example, where specialists under sort of microscope, or under a sort of microscope, or in context of pathology, can identify the sort of cellular findings in around some of the cellular findings in around the sort of pathophysiology of post renal and acute kidney injury and acute renal failure sort of findings, and so chronic renal failure is practically an irreversible damage of renal failure. It is frequent for patients to be symptomatic or asymptomatic, so patients can have, or recipients can have, some symptoms, or they may not have symptoms. The GFR, or glomerular filtration rate, will go down less than 10% of normal in patients, depending on severity, and the percentage of damage of a recipient's renal function from usual to sort of the sort of more detrimental symptomology or symptoms differs in recipients. In a patient, in recipients diagnosed with, for example, polycystic kidney disease, it may be at least 20 years or 2 decades before clinical renal insufficiency occurs. Some glomerulonephritis may destroy both kidneys in a month, and while some glomerulonephritis may destroy both kidneys in a month or less. CRF or chronic renal failure is not a diagnosis, but um, but more a clinical disease in around renal insufficiency. And there are three main groups of diseases that lead to CRF or chronic renal failure, and they include, for example, parenchymal renal disease, again, sort of mainly due to glomerulonephritis, primary or secondary complexes, chronic tubular interstitial nephritis, and polycystic polycystic renal disease. Uh, arterial blood pressure is normally a secondary condition of renal failure that and therefore must be dealt with accordingly. Um, Obstructive renal failure caused by obstruction of the urethra, for example, um, uh, of the urethra, and sort of enlarged prostate, enlarged bladder, and vesicoureteric reflux or VUR, and posterior renal valves and renal stones have been evidenced. CRF or chronic renal failure also implies permanent injury to renal pathophysiology, and the normal renal architecture is gradually replaced by scar tissue. One of the best ways, to an extent, to describe chronic renal failure or CRF is to invoke the so-called single nephron theory. So imagine a recipient or a patient only possessed one nephron. The question is, what would happen? Well, in the first instance, the glomerular filtration rate, or GFR, would be very low. So circulating concentrations of, as per mentioned, blood, urea, and nitrogen, and primarily the urea, the sort of urea, the urea aspect, will and would rise tremendously. Consequently, urea will act as an osmotic diuretic, because after osmotic reabsorption of water and solutes by proximal convoluted tubule, the remaining high urea salt will counteract with the with any ADH driven urea concentration. CRF, chronic renal failure, is therefore associated with diuresis, one of the relatively fixed osmotic one of relatively fixed osmotic of osmotic strength, and the net result is that patients or recipients are unable to regulate fluid volume, so cannot tolerate or would not be able to tolerate increases in fluid intake, and or dehydration resulting from a decreased or increased extrarenal losses. The remaining biochemical features of chronic renal failure become sort of more evident. A metabolic acidosis ensues because the remaining nephrons and the urine into which and into the urine which they are pumping concentrated hydrogen ions are saturated. The capacity is insufficient for the excretion of normal daily metabolic generation of hydrogen ions. If the original disease process is primarily tubular interstitial, for example, the capacity of the tubule cells to excrete acid will already be suboptimal. Diagnostic investigations in nephrology diagnostic investigations in nephrology have advanced. However, at the same time, potassium potassium or sorry, I say diagnostic investigations in nephrology have advanced, but also generally in laboratory and aligned to laboratory medicine. Potassium is almost entirely reabsorbed in the proximal convoluted tubule to be resecreted in substitute for sodium at the distal convoluted tubule. Hyperkalemia or high potassium is therefore usual in chronic renal failure because in saturation similar to that of hydrogen ions, the capacity of the remaining terminal convoluted tubules to secrete potassium is exceeded. If the damage is predominantly proximal, then the early reabsorption of potassium is incomplete, and the patient loses potassium in urine to develop hypokalemia, so low levels of potassium, and or a total deficiency of potassium. Among other substances excreted at a reduced rate in chronic renal failure are drugs that may be administered in smaller or less frequent doses in a few toxic examples such as gentamicin, the immunoglycoside gentamicin, and or digoxin. Digoxin would require monitoring of serum concentrations. Hemodialysis as a form of renal replacement therapy or kidney replacement therapy, depending on which terminology is used, is generally successful for most pediatric renal sufferers with both acute and chronic renal failure, and has generally advanced in terms of overall treatment to pediatric renal recipients. Hemodialysis at the same time is a physical development of transfer through a semi-permeable membrane, and was first described by Thomas Graham, someone referred to as Thomas Graham in 1861, and it was not until the 1940s the initial series of patients or recipients to be successfully treated with or against acute renal failure or ARF by dialysis was in the 1940s. One of the main concerns specialists or nephrologists have had is how much dialysis is compulsory for health. And at the same time, this is and has been a major point in both aligned to both pediatric recipients and adult recipients and adult recipients in line to renal failure. The traditional form of access for hemodialysis has been through the insertion of a subcutaneous fistula, where there's a joining of an artery and vein, and thus causing an increase in blood flow, and generally is an anastom where the joining is prominent or a basis. It is referred to as an anastomosis, and the anastomosis is generally fixed into the non-dominant arm, for example, as at least as part of the standard procedures in context of access for recipients receiving or receiving treatment, or this form of or forms of hemodialysis. This also involves an operation. This involves an operation or surgical procedure to bond an artery to a vein, and thus increasing blood flow. However, in pediatric recipients, the fistula can unfortunately be hard to generate or see or identify an increase in blood flow owing to number one primarily around the diagnoses in recipients in the pediatric population. And pediatrics are diagnosed with forms of renal disease owing to for example, in around the diagnosis of, for example, hemolytic uremic disease, hemolytic uremic syndrome, or HUS, as a form of diagnosis. Pediatric recipients are diagnosed generally HUS completely more often than not obliterates the veins and arteries in pediatrics, thus making it challenging, or can make it very challenging for patients, pediatric patients or pediatric recipients to receive appropriate renal replacement therapy, at least in line to hemodialysis, or as a main form of renal replacement therapy. At the same time, it can take time to produce. It can take time for the maturation of in pediatric recipients where anastomosis has taken place, and at the same time it can take time to produce. It can take time to mature, or where the fistula takes time to mature, and at the same time, where a fistula has matured, for example, or has matured, the cannulation of the fistula can cause and can be problematic. Other means of access consist of a catheter placed into the jugular vein, or near the near the neck, and hidden subcutaneously, so that it is exposed, so that it is where the neckline is exposed. The success of regular forms of renal replacement therapy for pediatric recipients in irreversible chronic renal failure has established nephrology, or pediatric nephrology, as a specialty, sort of separate from general medicine. Acute dialysis also has given sort of an anticipation of saving patients with acute renal failure, and has reduced mortality in this condition. Dialysis, at the same time, nephrology has advanced, or the specialty has advanced, and has also enabled other forms of dialysis to take place, and is more appropriate in the pediatric populations. It does depend on sort of etiologies, or in around the etiology and the condition of recipients. This means pediatric recipients are still able to attend school, for example, and perform academic activities. In adults, it can cause lifestyle complications. For example, it can cause anxieties, and cause issues owing to the effects of urea. Urea can in older recipients can cause issues. Continual ambulatory peritoneal dialysis, or what's been referred to as CAPD, CAPD or peritoneal dialysis or PD is applied more to more to the acute patient. It is slower. It is a slower form of renal replacement therapy, but that's a slower form of renal replacement therapy, but also a sort of more gentle method of treatment compared to hemodialysis. It is usually can be carried out at a patient's or recipient's home, and after a renal nurse or a specialist nurse has informed, for example, parents and trained the family in around the different aspects aligned to PD to be able to carry a sufficient dialysis in a pediatric recipient in context of CAPD, continuous ambulatory peritoneal dialysis, or PD, CAPD or PD. A Tenkov catheter, so a sort of plastic catheter, if you like, is placed or inserted into the peritoneal section of the abdominal cavity under general anesthesia. In around the Tenkov, in around the neckline for hemodialysis, for example, patients or recipients have are put have a local anesthetic, and the in line to peritoneal, in around the Tenkov catheter, or plastic catheter that's placed in the peritoneal section of the abdominal cavity. This is a procedure, a surgical procedure that has been historically under general anesthesia. The tube does not enter a blood vessel. Enter a blood vessel. However, the disadvantage with CAPD or PD is that it can require, for example, 4 or 5 bag exchanges, 4 or 5 bag exchanges a day, roughly, where each bag exchange is done every 30 minutes, anything from 30 to 40 minutes within each bag exchange, which can put a considerable amount of anxiety on parents and the guardian. In adults, in the adult population, in adults it tends to adults tend to be more suited to PD or CAPD, owing to routines allowing in around where the bag exchanges can be suited to the daily sort of routine of those in the adult population diagnosed. Another form of dialysis is also continuous cycling peritoneal dialysis, or CCPD, and this procedure of dialysis is carried out again in a patient or recipient's home overnight, and whilst the patient or recipient is asleep. A device measures the quantity of fluid that is run all the way through the abdominal cavity and out each cycle. Patients or recipients may be able to have a day off treatment. Normally for pediatric physicians or consultant nephrologists to decide. Intermittent peritoneal dialysis, or IPD, is also another procedure as another procedure. However, in around IPD, this format of treatment is a procedure in pediatric renal recipients, that may not require that much of dialysis treatment. The format of treatment is by and large carried out, or has been historically and evident, and carried out in sort of hospital environs twice a week, whilst a renal recipient is asleep. So that draws this audio podcast delves into the generalities, if you like, around renal failure, and again, on as part of this audio podcast, there will be some citations linked to sort of literature around sort of the other sort of important aspects around this audio podcast, will be available on social media and around this audio podcast. This has been an audio podcast as part of the Erythropoiesis edition, as part of the Hurricane Plexar, an audio podcast as part of a Labonix Vendip, and an audio podcast as part of a Storm Labonix production. Thank you.